I know we mentioned the level 3 and level 4 trauma centers already, but the level 3s are more your further outreach. Like I said, Hays, Kansas, I believe, is one. Garden City, St. Catherine Hospital could be one if they put in the paperwork. But I don't know if the hospital is actually interested or not. But they have the capabilities. So they're your tertiary centers. They're going to stabilize. They have a little bit more capability with imaging and so forth. And then your level 4s are, they provide advanced trauma life support. They do initial resuscitation. And then they prepare for transport out. I'm not sure if they can, some may or may not have any kind of operation or OR capabilities or not. These are just, like I said, they're, in the grand scheme of things, they are a Band-Aid station. Your designated trauma centers generally offer unique services. They have burn centers, pediatrics, psychiatric, perinatal, cardiac, spinal, poison centers. The pediatric trauma center that I worked at in Missouri was also the local or the statewide trauma center. I worked with the toxicologist in charge of the poison control center. They were also a level 1 pediatric trauma center for the state of Missouri and Illinois as well. When in doubt, you can always contact Online Medical Control for advice and support. Online Medical Control is there to answer your questions. When in doubt, don't hesitate to use them. That's what communications is for. And it also helps your doctors get to know your thought process and build that rapport with them. In some areas, paramedics provide primary care and then transport. New Mexico, several years ago, piloted a program. I believe it was called Physician's Extension. For the more remote areas, they were training paramedics in suturing and antibiotics and things like that, and they would actually take care of hikers and stuff like that at the scene. They would suture lacerations, administer antibiotics, or prescribe an antibiotic based on training and education and medical control, and then set up an appointment for the person to follow up in the next several days. Then treat and release. Paramedics on scene assess the patient, provide emergency care, and leave. They do not transport. We've all refused calls. Not refused, I apologize. That's wrong terminology. We have not refused. We've had patients refuse treatment and transport. We've had them accept treatment, refuse transport. Patients are allowed to do that. There's no way we can force them to go with us if they are alert oriented and able to make their own decisions. If they are not alert and oriented, or if they are confused, combative, not wanting to but not wanting to cooperate either at the same time, that would be a time for law enforcement to become involved, as they are the only ones who can put the patient into a protective custody situation. That patient's care and decision-making abilities. We get into transfers. When in doubt about a patient's ability or stability for duration of a transport, capabilities of receiving facility, contact medical directions. So this is what I brought up before. This is where we need to know what the receiving facility is part about. So we're going to talk about transport or transfers for a moment. Go inner facility. Oop, spelled that wrong. Inner facility. Transfers. So going from lower level of care to higher. To higher level of care, or potentially from higher to lower based on patient's condition, prognosis, what have you. This may be a going higher level of care would be traumas, needing more appropriate or more invasive care, needing more, whereas your bottom from higher level to lower level would be return to swing bed for rehab, swing bed, rehab, hospice, returning home from a distance, that kind of thing. So if you ever are in doubt of the patient's stability for the duration of the transport, this is where you need to know how far you're going. So again, we talked about this earlier. We have little hospital, we're going to bigger hospital, complex, and it's 3 hours ground. It's 1.25 to 1.5 hours by rotor, or 45 minutes to 1 hour fixed swing. Okay, so is your patient stable, and do they have a good chance of remaining stable for 3 hours? Is that appropriate? You've got to be able to read the labs. You've got to be able to see the trends. You've got to be able to go through that patient's information. I have come and gone to hospitals where the nurses refuse to let me open the patient's record, saying that is a HIPAA violation. It is not a HIPAA violation. That is a clear misunderstanding by the RN or the sending facility that you are in direct patient care. You have access to that patient record. HIPAA does not apply in this moment. Not to you, anyway. Of course, you're not going to go blab this to everybody between here and the receiving hospital. You are going to maintain privacy, but you need to know the trends. You need to know what the patient what happened to the patient. You need to know what was done to the patient. You need to know how they've reacted to that patient over the last period of time since this has happened. You need to know the history. You need to know the trends, and you need to know how they've progressed so that you can adequately anticipate what may be happening, what may happen in the next 3 hours, in the next one and a quarter to 1.5 hours, or the next hour, depending on the mode of transportation that you are involved in. When you get handoff, you will arrive at the patient's bedside. Theoretically, the handoff takes place before the patient is placed on your cot or your gurney or your stretcher, whatever you want to call it. Before the patient is moved from the hospital bed to your bed, you should get a complete handoff report from the nurse or the doctor, or both if necessary, before you take custody of that patient or care of that patient. And the reverse is also true. When you give handoff to the higher level, you will give report to the nurses and the doctors, whoever's there to listen, and take report. It has to be an RN or a physician, so an RN or higher. They have to be equal level of care. You cannot hand off to a CNA or an ER tech. They have to be of equal or greater level of care when going to higher level of care. You pass that you give that report, and then you take the patient, and they are physically moved then to the hospital bed. That is theoretically how this is supposed to happen. We all know that it happens differently in different places, and urgency plays a major factor in that matter. Okay, as we've been going on talking about transfers, interfacility transfers specifically, one of the first priorities that we have during the transport is the patient. That is why we need to ensure that this is the proper method of or mode of transportation, be it ground, rotor, or fixed wing, that it's safe for the patient, that the patient is stable enough to make it through the transfer without without condition degrading, and that treatment can be given as needed, as appropriate. That includes also personnel within the back of the ambulance with the patient. We're not going to send an EMT basic with a ALS transfer to take care of in the back. The EMT is fine to drive. However, they are not able to give the meds, nor do they have the knowledge and experience base to properly assess the patient. Some may have it, but they don't have the certification level and the scope of practice to take care of the patient within the back of the ambulance. All documents provided by the sending facility need to be turned over to the receiving hospital or the receiving care provider, the RN or the physician, or both, along with a copy of your run report. That makes it difficult for electronic run reports. However, transferring hospitals or transporting hospitals within a database or within the run sheet database, Kansas uses ChemSys. There's several of those out there that they have access to that run sheet as well. It doesn't hurt to go ahead and have the receiving nurse sign your report saying that you delivered the patient and that they received report. Documentation is a huge thing, alluded to that with them having signed your run report. Patient care report is to be completed in its entirety as soon as emergency care is completed. This tends to be a hot ticket item, especially as you get on in EMS and time in EMS and throughout your career. We all tend to put things off, especially if it's a seemingly unimportant or a average call, if you will. The refusals, dog bites, things like that, people tend to put off. Sometimes those are the most important ones that you need to get done as quickly as possible. Refusals, in my opinion, need to be taken and they need to be documented even more thoroughly than a code in a lot of cases, because there you're running the risk of the patient degrading, and it may have been something you missed. It may have been, it may be completely unrelated. However, the fact that they are now in hospital care prior or after your initial visit or your initial call, you need to document that. You need to document it well as to why they refused your treatment. So we want our PCR, patient care report, completed ASAP. A lot of these can be done while with the patient in the back of the ambulance. If your patient is involved, of course, you're not going to be able to, but you can potentially get it written while you're at the hospital. Or as soon as you return back to your post or your station, you need to sit down and complete that with all signatures and everything needed. Make sure your notes are recorded in PCR. If you write on the back of your glove, take a picture so you can get those. Make sure everything is included, everything that you need. Accuracy. and completeness. Accurate, meaning times, doses or dosages, medications, locations, both physical on the body, or physical as in geographic, anatomical on the body. Make sure your locations are accurate. Make sure your times are accurate, your dosages are accurate, your medications are accurate, your locations are accurate, where you were and where the injuries were. This could be a criminal investigation, and your run report now is evidence for one or the other, for the prosecution or the defense, or potentially both. This is a legal document. Make sure you're recording only observations, not opinions. Just the facts, ma'am. Just the facts. Make sure what you're writing is complete, accurate, concise, and just the facts. And then, of course, returning to service. After we finish the call, we return to service. That doesn't mean after writing your report. As soon as you drop your patient off and you have completed everything that you need to complete at the hospital, you need to return to service as quickly as possible. But returning to service has its own set of requirements. It would be nice if we could call out of service to write our reports. Unfortunately, that is not always the case. Depends on your local protocol. If they allow for it or they expect that, then that's good. But most places want you back up and running. So in returning to service, we must make sure that our unit and ourselves are clean and decontaminated. Both unit or ambulance and ourselves. If you knelt in something wet and sticky and it wasn't yours, you need to get that off of you. Properly dispose of trash, be it regular trash or red bag. Make sure you are disposing of it properly and in the proper receptacle. Restock. Supplies. And then replace and stow equipment. Make sure everything is back in its place. Refuel. Whatever your policy states, some policy states as soon as you hit a quarter tank of gas or diesel, you need to refuel your unit. As soon as you get to a half a tank, you need to refuel your unit. You need to ensure that you have enough fuel to respond anywhere within your response area. Review the call. Talk with your team. How do you think it went? How do they think it went? What could have been improved? What could have done better? Do your own informal QA/QI. This will also help you in writing your report and making sure that your report is accurate, concise with everybody involved. Your partner and anyone involved with the call should also be reading your report to ensure accuracy and completeness of the report. After all, they are mentioned in it. They should be reading it, if not contributing to the writing of it. And then watch for signs of CISM. Spelled that incorrectly. Watch for people that are not handling the call well. Keep an eye on them. Talk to them. Let them know you're there for them. This can affect us at any time, on any call. It may just be a memory of something that happened long ago that brought it back to the surface. Just keep an eye on each other. We've talked about some of this before, so we're not going to spend a whole lot of time on it. However, some of our additional responsibilities are training civilians in CPR. CPR training. EMS demonstrations and seminars. I have spoken to multiple organizations, the Lions Club. I have spoken to Girl Scouts. I have spoken to multiple other civic organizations as to EMS, the future of EMS, and the importance of EMS in the community. They all really enjoy it. It's easy to talk over their heads, wow them with your brilliance, dazzle them with your BS, whatever. But they enjoy it. People enjoy it. It's a vital part of getting us out there in the public so they know that what we're doing and we're not just hiding in our stations, in our posts. Along with CPR training is teaching first aid. These are things that are coming around more that we should be doing as EMTs and paramedics, as EMS as a whole, that the fire department has been doing for decades. They are the masters of self-promotion. We need to follow their lead if we're not associated with the fire department. Organizing prevention programs. Injury prevention programs, safety seat inspections, child safety seat installation and inspection, injury prevention program, fall prevention program for the elderly, helmets, knee pads, elbow pads for kids on scooters, bicycles, and skateboards. We need to be involved in these. We need to organize these. We need to get people involved and up and with us. It helps us out in the long run. And then, of course, professional development. Professional development, continuing education, not taking the same old continuing education over and over and over again. The same ACLS courses, the same CPR courses, the same stroke courses. Yes, we have to recertify in that stuff, and that's all well and good. And yes, they allow us to use it as continuing education. However, continuing education is supposed to be exactly that. It's supposed to be uplifting our profession. It is supposed to build our knowledge base. And yes, we do learn things as we go. We learn more things. We get different instructor, which I encourage you to go to different instructors and seek out different information than even what I'm presenting to you. The more exposure you have to the more opinions, the better and broader your knowledge base is going to be, which is what we need. We need to push that. Along with additional duties is administrative duties. Nobody likes the office job. That's why we got into this, so we're not stuck in the office. We can go out. We get to be outside. We get to be with the people. We get to be outside of a cubicle. Instead of looking out the window, we're outside looking in the windows, thinking, suckers, you guys are stuck inside 8 hours a day. And we are playing out in the weather. We're playing out in the sunshine, the rain. Sometimes it's a blessing. Sometimes it's a curse. Depends on how you look at it. So we have station duties. So, and these are things you'll be expected to take part in as a student as well. Station duties, cleaning, mopping, trash, dusting, windows, etc. Household duties, that's station duties. We also have record keeping. Training records. Maintenance. Budget. Etc. Special projects. New equipment. Research. New protocols. New division. Say you're moving into tactical medicine and you're wanting to start a SWAT division within your department. Of course, you're going to be a little higher up than street level medic, but these are the things, special projects that are going to handle. They're going to look into new equipment research. They're going to research new protocols, research new divisions. What can we specialize in? Is there something we can do that's needed in our area that nobody else is doing? And then along with those things is developing interagency relationships. Going to your neighboring county and making friends with the service over there. Finney County, Gray County, Kearney County, Haskell County, Scott County all surround Finney County. We need good relationships with these services. They need to know that they can call us if they need help, and we need to know that we can call them if we need help. Maintaining these relationships is a good thing. We tend to get tied up in our own business, and we neglect to go out and meet with these people until it's time. Going over and meeting up and sharing training, doing group trainings, offering help with trainings is a great way to start those relationships. Get people together, work together, know what each other has, what your capabilities are. And then those other projects of, oh, these guys have a protocol I like. What can we do to make that happen in our area? Oh, I'll call them up and see how they did it. Let's talk to their medical direction. Let's talk to their service director. Let's talk to their people that put this together and see what all is involved. And that helps with getting the community involved too. These smaller communities like we have out here in the western part of the state, we're all interconnected in some way, shape, or form. Everything comes together in one spot. Usually, there is a center of the community where everybody comes together and everybody expects this is where something is going to be held. This is the ideal location for something to be held because we are located centrally. It's equidistant for everybody to come to us, and we have the facilities type of thing. Then you get your community involvement. Get your community involvement and help the public learn how to recognize an emergency. Help them recognize an emergency. Provide first aid and CPR. Properly assess the EMS system. They're our biggest critics. They're the ones who elect the officials who run our services, that choose who our bosses are, that dictate the policies and protocols and the things that we get. You make friends with the public, it's easier to get the things that you want and that you're asking for, especially if you're involved in the community. You're helping to educate them on when is there an actual emergency. What do I do when I recognize this emergency? How quickly does first aid need to be rendered? Can they call? Do I need to call EMS right now, or do I need to call 911 right now? Successful community involvement decreases mortality. Because it saves lives. The more people you have trained to provide first aid and CPR as soon as they recognize the need, your mortality rate decreases. Lives are saved, makes families and communities happy. The risk of illness and injury also decrease, because you have educated them on fall prevention. You've educated them on the importance of helmets, elbow pads, and knee pads, on hearing protection in loud environments, on eye protection, doing anything that with flying debris. You have educated them how to properly render first aid to mitigate the injury prior to EMS activation or even involvement. These are all things that are good outcomes of community involvement. This also supports our primary care. Involving the physician, local physician community. Get with them and what do their patients, what do their clients, our patients, need? What is the health needs of the community? So if we support primary care, how can we support primary care? We can promote wellness. And prevent illness and injury. We reduce the cost of service. By decreasing the burden on the system. Because if we promote wellness and prevent injury and illness, are we going to be needed as much? We're trying to work ourselves out of a job. It will never happen. They will always need us. No different than the fire department. We will always be needed, but we can lessen the burden on ourselves by promoting these things, by promoting wellness, by promoting exercise programs and illness and injury prevention programs, teaching little kids how to wash their hands after they do stuff. Easy things, and we could integrate this early by involving students, school children, their parents, all the way up through high school. Just introduce and reinforce and reinforce and reinforce. And then always, the patient receives appropriate care based on need, not cost. Again, no ambulance that I've ever worked on had a credit card sign in its window. We don't care. That's not our job. Our job is not to bill. That's somebody else's job. Our job is to provide appropriate emergency care based on the need for that emergency care, not the cost of that emergency care. We are going to do our jobs regardless of that person's ability to pay. And we need to make sure that the public knows that. Yes, they will receive a bill. That's nature of the beast. We cannot help that. But that doesn't mean that they're not going to get treatment. Getting citizens involved with EMS, with our services, helps give the insiders a view outside. Helps us see what they're seeing. We see what we see, but we're educated on what we do and how we do it. The public doesn't know what our education is. They don't know the classes and the time and the effort that was taken to get to this point. Our families do. Our families have the best idea. But the general public does not know. So we want to get citizens involved for multiple reasons. We want them to see what we see. We want them to know most of what we know. We want to get their view of us, and we want to give them our view of them. This will help give an objective view to our quality improvement and problem resolution. So if there's a problem, there's something that needs to be solved, we're running into problems, trying to figure it out, maybe we need the outside view. Maybe we need the public view coming in. Involve the members of the community and use them in development, evaluation, and regulation of your system. Get their thoughts, get their views. What do we need to do? What can we do to make things better? And as we get into personal and professional development again, it's our responsibility to continue personal and professional development. It's on us. Our service may pay for it. Our service may provide education. But again, we can stagnate in education. We need to expand it. We need to pull in from everywhere that we can. We need to know what other people are seeing and doing, because what we're doing may not make sense to us, and we don't realize it doesn't make sense until we get that other view or that other approach. Professional development, again, we need to work on our own. This is our responsibility. As volume of calls decreases, training correspondingly increases. So if we're trending down in the volume of calls, are we practicing? Are we doing the things that we're trained to do as often? No. So we need to up our training. We need to review our previously learned materials and be willing and ready to receive new information. We have to be adaptable to change. Because it's always been done like this is the most dangerous phrase in any organization. We have to be ready and willing to change. It's difficult. I am one of those that does not like change. I find it very difficult. However, I have to adapt with it. Education is no different. What worked yesterday may not work tomorrow. And I have to be ready and willing to change to meet that challenge.